All of these drugs are the drugs that you're going to do drug cards on. These are respiratory care drugs, and respiratory therapists are very familiar with all of them. Here they are. So, if you look at the first page, which I'm going to start with the asthma drugs, and you don't even know what asthma is, but you'll learn. These are the asthma drugs, and you see they are referred to as rescue or reliever bronchodilators. So bronchodilators is a drug classification. Okay? We call them broncho, meaning airway, dilators. They open up the airway. Bless you. Another classification meaning bronchodilator is beta 2. Beta 2 agonists. So if I say beta 2 agonist, you know I'm talking about a bronchodilator. If I say bronchodilator, you know it's a drug that affects the airway, not the lungs. You all begin to learn the difference between the upper airway and the lower airway, right? Mm-hmm. All right. The bronchi and the bronchioles are in the lower airway, right? Yes. Because they're below the larynx. But you have bronchi, which are generation 0, starting at the trachea 0. But the right and left main stem, well, you have bronchi are generation 0 to what?
9.
Okay, I won't dispute that. And then the bronchi are what? Generation 10 to 19. So when we talk about a bronchodilator, we're talking about the airway only. We're not talking about the area of the lung where external respiration or gas diffusion occurs. So when we say beta 2 agonist or bronchodilator, this drug will open up the airways so ventilation can become adequate. All right? And so we call them rescue drugs or reliever drugs. Beta 2 agonists, bronchodilators. And you see the short-acting beta 2 agonists right here on the sheet, right? All right. What you see below it, you see ProAir, Proventil, and Ventolin. Everybody see that? Mm-hmm. All right. Whenever you see letters that are in bold or they're capitalized, that first letter is capitalized, that's always the trade name. So ProAir, Proventil, and Ventolin are trade names. You see below each one of those three, you see albuterol sulfate. What's that? The generic name. So it's 3 different companies, and I mentioned 2 the other day. It's 3 different companies that manufacture albuterol. Albuterol is the generic name. But here, and don't be concerned about manufacturers, I'm just making a point here. We'd be nuts if we had to know manufacturers. Teva makes ProAir. Teva produces albuterol. What do they call it? Teva. No other company calls it ProAir. Merck produces albuterol sulfate. What do they call it? Proventil. GlaxoSmithKline produces albuterol sulfate. What do they call it? Ventolin. Got it? So again, trade names will always be capitalized or the first letter will be bold. Now what I want you all to start doing, let's start looking at commercials. Who has time for TV and you in this program? But when you do have time, start looking at commercials and you'll see advertisement. Either the trade name is going to be all capital letters, or that first letter in the trade name, and if it's 2 names, the first 2 letters of each word will be capitalized, and or it could be bold. But generic names are always small caps. And that's how you know the difference. Okay, so we got 3 different companies producing albuterol. Next to albuterol, you have lev-albuterol. Lev-albuterol, trade name is Xopenex. And then next to, now these forms are MDIs, metered dose inhalers. And next to that is albuterol again, but it's nebulized albuterol, meaning this is the albuterol that you're going to administer through a small volume nebulizer. So that particular source of albuterol doesn't have a trade name. It'll just be albuterol, and you'll know that it's albuterol. You'll know its drug classifications, you'll know the indications, and you will administer via pneumatically powered small volume nebulizer. Okay? So I wanted to give you this. These 5 drugs, all 5 drugs, you'll do a drug card on. I haven't told you what's on the drug card, but I'll get there. Any questions with that? All right. Next to the relievers are Petroleum Bromide. Petroleum Bromide. Okay. If you look below under Atrovent and Combivent, Petroleum Bromide is a generic name. One company that makes Petroleum Bromide calls it Atrovent. See the vent in there, V-E-N-T? V-E-N, ventilation. Kind of see the names. Let's go back just to kind of see why a bronchodilator, which the company calls it what they want. But the first one calls it Pro-Air. Pro-Air is what? Somebody having a difficult time breathing? Let's give them some Pro-Air. Let's help them. All right. The next company calls it Proventil. See the Ventil? What's that? Ventilation. All right. And then you see the Ventolin? What's that? Ventilation. See it? All right. Okay, now go back to Petroleum Bromide. See the Atrovent? Okay. This particular drug is not a beta-2 agonist. But nevertheless, when we get there, I want you to know it. And it's called Petroleum Bromide, or it's called Atrovent. And we'll get to its classification. And now the drug next to it is called Combivent. Combivent. When you combine something, it's putting two things together, right? That's the combi. And then the vent is what? Something to put together. Okay, so here we go. The relievers, the rescue drugs, the bronchodilators do just that. They open up smooth muscles in the airway. That's what they do. And it's for an acute asthmatic and other type of patients too. But right now we're just going to stick with the asthmatic. Anybody in here asthmatic? What do you do? What do you do when you're having an asthma attack? How do you know you're having an asthma attack?
Can't breathe.
And how else? What else? Everybody who can't breathe doesn't mean they have asthma.
Usually it's really tight.
Very good. Tightness. Wheezing, that's what I'm looking for. Patients, asthmatics, will wheeze. Okay, and I'll tell you what that is. Now, Combivent is a combination of, if you look at it, albuterol sulfate, see it? That's part of it. But it's also the Petroleum Bromide. So this is a combination of 2 drugs. And anytime you have a combination of 2 drugs, that's called synergy or synergistic. It's on the sheet that I just gave you. Synergy or synergistic. A combination of 2 drugs. So these drugs are synergistic. Everybody with me? And even if you don't write it down now, I'm going to go through it again. Okay, so let me give you an example. Well, Kyle, come here. I'm gonna excuse you. Okay, synergy. I'm a bronchodilator, and I dilate the bronchi. I do my thing, okay? He's anticholinergic, and I'm not expecting you to know that now. He's anticholinergic, and he does his thing, okay? But now we have an asthmatic that doesn't necessarily respond to bronchodilators like he or she should, or, well, I shouldn't say like they should, like we would most effectively like for them to respond. But they don't anymore because they've had asthma a real long time. And then he alone is not going to help them because he's not a true bronchodilator. Got it? But now, I have a purpose and he has a purpose. But he can't fulfill his purpose without me because this asthmatic is not responding to me. So surely this asthmatic is not going to respond to him. Got it? All right. But now somebody comes along, great thought, and say, hey, let's put us together. And so they put us together, and me and him in one dose of a drug reaches the therapeutic effect. And to us together is referred to as synergy or synergistic. So when two types of drugs are combined together to achieve a therapeutic effect, it's called synergistic drugs. And combivent is synergistic. Thank you. We work well together.
A little flush.
You're supposed to be. All right? Okay, so the bronchodilators is one classification. This Petroleum Bromide is another classification. But then to the far right is combivent. And combivent is a combination of both albuterol and the Petroleum Bromide. And that handout that I gave you, that yellow handout that looks like it's just a little bit too much for right now, I'm going to explain why these drugs are combined together. Okay? Oh, we're going to go there. You have to be therapists. You shouldn't administer drugs if you don't understand how they work. Okay, so these are the beta-2 agonists. Okay, below are the controllers. And I'll explain what controllers are. Controllers are the drugs that asthmatics should be taking from day to day, even when they feel good. That's what the controllers are, and here they are. And then let's turn the page. And now you have inhaled corticosteroids. The other day, I don't know if it was yesterday, I mentioned DPIs. There's your dry powder inhalers. Okay? See them? Mm-hmm. All right. And then below that are your combination therapies. And what do you see with these combination therapies? Do you see two drugs? So what kind of drugs are they?
Synergistic.
They're synergistic. You got it. It's two drugs because all patients won't necessarily respond to one drug. They need two. And they may not need it forever and a day, but right now they need two drugs. And we're going to go through how these drugs work and what they are. And then down at the bottom you have inhaled corticosteroids. Does anybody know in general what a corticosteroid is? What's it for? A steroid? Not the ones for bodybuilding. I'm not talking about those.
Isn't it for inflammation?
For inflammation. These are anti-inflammatory drugs. Okay? All right. So I'll talk a little bit more about this. And I did bring my drug cards for you to see. But these are the drugs you're going to have to know. All of them you won't have to know the dosage, but you need to be familiar with them. All of them as respiratory therapists, we won't administer. But your asthmatic patients, your COPD patients, and your chronic hypoxemic patients will come to the hospital on these drugs. And when they come on these drugs, you need to be cognizant of what they're taking and the drugs that you may need to administer them, how they interact. Got it? So if nobody knows these drugs, pulmonologists and respiratory therapists know these drugs. All right? You may have a patient that say, you know, my doctor prescribed this for me 2 months ago. What is this? You need to be able to tell them what it is. Why am I taking this? And you need to be able to tell them a little bit more than just because your doctor said so. Okay? All right, so these are the drugs. I actually have this in color, but I didn't have enough of to give everybody one in color. But if you want to see these things in color, I have a handout over here for you. Okay, so hang on to that, all right? Let's look at this handout that I just gave you. And Evie, do you now have one, yes? All right. Sources of drugs. Drugs come from plants, and I'm just giving you examples. I'm not going to test you on this, but I'm just letting you. Example of drugs that come from plants is morphine and codeine. Okay. Minerals, antacids, laxatives, and mineral oils come from minerals. Just an example. Animals, insulin, thyroid hormones. They have synthetic or recombinant insulin now, but I want to say maybe 30, 40 years ago, patients that were diabetic and needed insulin, they either took pig insulin, they actually took the enzymes from pig, beef, but now they have synthetic, but nevertheless. Synthetic means man-made. And a lot of the drugs that we use are man-made. The synergistic drugs are man-made. So in one sense, when we talk about synergism, look at it in a positive connotation, we're improving. Before, a patient had to take this, and then a patient had to take this. Now the drugs are combined, and they only have to take one drug. So maybe 40 years ago, a patient had to take medicine 6 times a day. Now, because of these combined drugs, they only have to take it 3 times. Because each time they take a therapeutic dose, it's a combination of 2 drugs. Some people take antihypertensive drugs every day, and they'll take a diuretic. But now they have antihypertensive drugs where the high blood pressure medication and the diuretic is combined in the same pill. So only have to take 1 pill a day. Make sense? So that's synthetic. When we say synthetic, a drug is man-made. And all of them are not combined, but a lot. And I've given you examples where drugs are combined. And for some patients, that's a lot better. If it weren't, believe you me, pharmaceutical companies wouldn't be manufacturing it because they wouldn't make any money. So it's beneficial. And then recombinant DNA. That's an example of growth hormones, vaccines, and immunizations. So I'm just giving you examples of the origins of medication. Most drugs that we will deal with will be probably synthetic. All right, drug administration phase. And let me know if I'm going too fast. The drug, and this stuff is in the book, but Kathy Miller does her own thing sometimes. All right, the drug administration phase describes the method by which a drug dose is made available to the body. So it's the route of administration. It's the route of administration. It's the entry. How does it get into the body? Is it oral? Is the patient taking it via injection, which is intramuscular? Is it sublingual under the tongue? Or is it inhalation? Now, the drugs that you will administer and you need to be cognizant of will be inhalation. We administer all our drugs via inhalation. Does that make sense to you? Okay, so respiratory care drugs are administered via inhalation. All right. Routes of administration. There's 2 broad categories. The first is enteral. And this is just overall basic definitions. You might have had it in medical terminology. You might have come across it in A&P. Enteral. Enteral, the term itself refers to the small intestines. Enteric, you remember that word? Okay, it refers to the small intestines. But the enteral route is more broadly defined as drugs being absorbed in the GI tract. So what we mean is it's 4 routes. One is oral. Makes sense? You take it by mouth and it goes directly to the GI tract. It's only 4 routes of enteral. We actually don't, when we administer medication, although you're going to ask a patient to either take the MDI or your small volume nebulizer and put in their mouth, the route that we're administering is not oral. They're just putting it in their mouth. Let me make that straight. It is not oral. We don't administer inhalation drugs orally. Got it? Because the drugs that we administer don't go to the GI tract. And the definition of enteral, it goes through the GI tract, meaning you swallow it, it goes in the esophagus, and then it goes to the stomach. The drugs we administer don't do that. The drugs that we administer goes through the oral cavity. It just so happens that the GI tract and the respiratory system share the oral cavity. But the drugs we administer goes through the oral cavity, then goes to the larynx, and then to the respiratory tract or the lungs. So the drugs, again, we administer is not enteral. Got that? All right, this is when your anatomy and physiology comes in. Drugs we administer is not going to the belly, it's going to the lungs. So that's inhalation. All right? All right, so oral, rectal, can you believe that? A suppository. If an individual has to take a suppository, nevertheless, it's going through the back door, if you will. It's going to be absorbed by the GI tract. So a suppository is enteral. And then the next is nasogastric. Have any of you heard of NG tubes?
Yes.
Those that are in the NG tubes, nasogastric tubes. For whatever reason, maybe the patient is having, let's just say in general, GI problems, and they're not able to completely digest food or whatever. And a nasogastric tube, meaning a tube will be placed through their nostril, quite painful, I would think, uncomfortable, because it is an invasive procedure, and it goes through the back of the mouth, and it goes through the esophagus, and then what it does is aspirates fluids off the stomach. That's NG. And then whenever a patient has a nasogastric tube, liquid medication, obviously not a pill, liquid medication can be inserted through the NG tube and go directly into the stomach, and so that's enteral. And then another one is called a PEG tube, no big deal. A PEG tube is maybe a person has a problem with their intestines, or it could be, let's say, a cancer patient, or maybe a little 95-year-old man or woman, and they just don't have an appetite. And the physicians and the family have gotten together and decided they need nutrients. Make sense? So they're not swallowing. They don't want to do that. So they'll put in a PEG tube, and through that PEG tube, they can give them what we call TPN, total parental nutrition. Okay, and they can give them high caloric liquids, Ensure, Boost, and vitamins and nutrients that they need. So those are the 4 sources for enteral, just for your information. But again, just because we administer our therapy through the mouth, how we administer therapy is not enteral. Enteral means it has to be absorbed by the GI tract. The drugs that we use, as well as these drugs here, are not absorbed by the GI tract. Okay? All right, so the next broad category is us, parenteral. Parenteral. Have you heard of the Greek term para, P-A-R-A? What does para mean? Around, beside. So parenteral means around the GI tract, beside or along the GI tract, which implies any route other than enteral. And that's why I emphasize drugs we administer, although we use the oral cavity, it's not enteral, it's parenteral. Okay. Parenteral can be A, intravenous, that's directly into a vein. That's invasive. We don't do it, but nevertheless it is. It can be intramuscular, That's an injection. It can be subcutaneous, injected right below the skin. How many of you did the Mantoux skin, the TB skin? I'm calling it Mantoux, like you know. That was subcutaneous, right? Right below the skin. All right. Transdermal. Trans means what? Across. Dermal is what?
Skin.
Okay, transdermal. Application to the skin. Like a cardiac patch, or it could be a smoking patch. Someone's trying to stop smoking, and they'll put a patch on. Any of you ever been on a cruise, and they gave you a patch to alleviate nausea? Scopolamine. That's transdermal. Okay. All right, and then E, that's us. I probably should have put that in bold. You can highlight it, you visual people. Inhalation, given by inhaling for a systemic or local effect in the lungs. So drugs that we administer is during ventilation. What part of ventilation? Inhalation or inspiration?
Inhalation.
Right. So drugs that we administer, all these drugs on this are parental, and it's via inhalation. Okay? All right. Aerosolized agents are given to target the respiratory tract for a local effect in the lungs, and technically it's really not in the lungs. I'm going to be very specific, because your respiratory system is broken up into the upper airway and lower airway, right? Mm-hmm. But it's also broken up into the airway itself, the bronchi and the bronchioles and the lungs. That's how we look at things. What are we talking about? Is it a condition of the bronchi? Is it a condition of the bronchioles? Or is it a condition of the lung parenchyma, which is the alveoli? So technically, when we give, or I want to be correct, when we administer drugs, we're not really administering drugs to assist the alveoli. When we administer a beta-2 agonist, we want it to have a bronchodilator effect. And then if we understand this, if we know the drug has an effective beta-2 agonist effect, then we know the airways will open and relax, they'll chill, and then as a result, ventilation will be adequate. Does that make sense? Okay. So if ventilation is adequate, then gas exchange will be adequate. Make sense? All right. So the drugs that we will administer has a direct effect on the bronchi and the bronchioles. It does not have an effect. Have you got the type 1, 2, and 3 yet, cells? It does not have an effect on type 1, 2, and 3 alveolar cells. Not at all. It's supposed to do what it's supposed to do before it gets to the lungs.
So
yes,
basically it has an effect on what's called the conduction zone, right?
Conduction zone, that's it. Airway zone, yep. It has a direct effect from generation 0 to 19. Any questions? So as a respiratory therapist, you look at the respiratory system, upper airway non-sterile. And believe it or not, your anus is cleaner than your upper airway. Your upper airway takes a lot of hits. It really does. And then you have your lower airway, which is sterile. And you have all these defense mechanisms in place to protect the lower airway. Okay, another way to look at it, we have our conducting airways, as Ebony said, the conduction zone. That's where ventilation occurs, and that's all. Ventilation. Oxygen in, carbon dioxide out. That's the function of it. Then in the respiratory zone, or the alveoli, that's where gas exchange occurs, right? Mm-hmm. And gas exchange between the atmosphere and the lungs is called external respiration. Write it down. Call it external respiration. Perhaps Ms. Manal is saying gas exchange. Another name is pulmonary gas diffusion. Same dog, big Jane. All means the same thing. But I use those terms because internal respiration is something different. External respiration. So your conducting airways is where ventilation occurs. From the mouth to the 19th generation of the bronchioles. That's ventilation. After it gets to the 20th generation to the 28th generation, that's considered your alveoli or lung parenchyma, and that's where gas exchange occurs. And we call it external respiration, or we call it oxygenation, right? You all got that? Yes, no, maybe? Am I speaking Greek? What?
Can you give the definition for external respiration one more time?
Gas exchange. Have you all gotten through that physiologically?
So that's generation like 23.
28. Did you go over that yesterday? Tuesday? She will. I'm not going through the physiology. That's where the CO2, the oxygen crosses and goes over into the blood, and the carbon dioxide leaves the capillaries and goes into the, leaves the arterial blood and comes into the lungs. That's where gas exchanges. That's how the CO2 gets out, and that's how the oxygen gets in. All right? All right, so back to these drugs. These drugs are only for generation 1 through 19.
All of these?
All of what?
All of these drugs in this section?
These
Oh,
drugs.
I'm sorry. Okay. First, 0 to 19.
0, I don't say 0 because 0 is the trachea.
Oh, okay.
So I'm just going, 0, trachea is 0. Okay. So we'll say 1 through 19 because the large bronchi begin at generation 1.
Yes.
Yes.
Okay. Got it? Anything I teach, I can tie it into another subject.
So
Yes, sir.
Are there any drugs that you're ever using the 0 to 28 where the gas exchanges?
Oxygen,
Oxygen, that's it? Okay.
heliox, nitric oxide. Yeah. But in perspective of beta-2 agonists or bronchodilators, generation 1 through 19,
Okay.
and it stops. Yes.
So in general, asthma is, you're just dealing with the ventilation. That has nothing to do with alveolus. Is that right?
It's not alveolus, it's alveoli.
Alveoli.
Yes. And that's not Kathy's way, that's the correct way to pronounce it.
Works for me.
It's not going to work in a clinical environment.
No, I mean, what you just said works for me.
You can't go talking Greek to someone who speaks Spanish. All right, alveoli. One is alveolus, plural is alveoli. You have one syllabus for this class. For all of your class, you have syllabi. Okay? All right. So, your drugs, beta-2 agonists, as well as other drugs we'll go over, actually affect the conducting airway. All right? A beta-2 agonist or bronchodilator. Does it enhance gas exchange? No. What's it for? Relax bronchial smooth muscle. Okay, did I say cardiac muscle? No. Did I say renal tissue? No. I said bronchial. Where are bronchi located? In the respiratory tract. Okay? Make sense? All right. So it relaxes smooth muscle. So we, again, our beta-2 agonists that you'll administer are via inhalation, which is the parental route. All right. Next is topical drugs that can be applied directly to the skin or mucus. And then last, which is G, sublingual, under the tongue. And it's not swallowed. So you have a patient who has angina, they're having chest pains, and they're given Nitrovid, Nitrostat, other drugs, whatever. Nitroglycerin is a vasodilator. And we tell them to put it under their tongue. They're putting it in their mouth, but it's not enteral. Because enteral means it's absorbed through the GI tract. When someone puts medication in their mouth, sublingual or subbuccal, that's the same thing under their cheek, it's not being absorbed in the GI tract. It's being absorbed by the coronary arteries. So just because something is going into one's oral cavity doesn't mean that it's enteral. Repeat what?
What you said about the pills going to the GI tract.
When it's enteral, it has to go through the stomach. And just because medication goes into the mouth, it doesn't necessarily mean that it's enteral. If it's not being swallowed, it is not enteral. And when a patient takes a sublingual pill, they're not swallowing it. They're putting, just like if, what did we put in the mouth? A throat lozenge. You're not supposed to swallow throat lozenges, are you? That doesn't go into your GI tract. So it's technically not enteral. Everybody understand that? Now, again, one part that the digestive system shares with the respiratory system is the oral cavity. But after that, no more. So the oral cavity, you can put stuff in it, but you have to know where it's going. And if it doesn't go directly into the GI tract, it's not enteral. A pill you swallow, anything you swallow, that's enteral. You put it in your mouth and you don't swallow it, it's not enteral. And the drugs that we administer are not enteral. Make sense? All right, any questions with that? Did you learn something?
Yes.
All right. Okay, pharmacokinetic phase, I went through that, absorption, distribution, metabolism, and elimination. Any questions? And most elimination can be through urine, but sometimes elimination is also through your feces. And so that's why it's dangerous for individuals to have packed bowels, because that in itself can be toxic and infectious. All right, pharmacodynamic phase. It's the phase that describes the mechanism of the drug action by which a drug molecule has an effect on the body. So, in short, we call these drugs bronchodilators. That's a classification, okay? But its pharmacodynamic phase is a beta-2 agonist. What I'm saying is, what effect is it going to have on the body? So a beta-2 agonist has a bronchodilation effect. And so in short, we call them bronchodilators. So these are terms that will be used synergistically. So if I say beta-2 agonist, or if I say bronchodilator, it means the same thing. It's a drug that we, as respiratory therapists, will administer, or the patient could be taking it home. And we know they have a problem for some pathological reason, and right now we'll just stick with asthma. That's not the only reason, but for right now we'll stick with asthma. And I know I haven't defined asthma, but they have asthma. So they have a problem with ventilation. And so we have to provide a drug, a beta-2 agonist drug, to help open up their airway for adequate ventilation. It's going to help ventilation. It's going to help them breathe easy. That's Kathy Miller's whole concept in respiratory care, breathing easy. And we, who don't have lung problems, and I have asthma, but a long time ago, because I know how to control it now. Actually, that's why I got into respiratory care. What is this? This stuff is going to kill me. And so after I went to school, I learned how to manage it. So we are responsible for helping those individuals and assist those individuals with their ventilation. And then if we find that for whatever reason they need oxygen, we can't control oxygenation. That's physiological. We can assist the patient in their ventilation, but whether they adequately oxygenate or not depends upon their pulmonary status. Make sense? So as I was saying yesterday, and I don't want to get off on the blood gases, we can give a person 100% oxygen, but that doesn't mean their PO2 will rise above 50. And if it doesn't, it's really nothing we can do about that. That means they have some extensive lung damage going on, and it's probably irreversible. Make sense to you? All right. Again, without pathophysiology, that can happen. You will see. And those kind of patients, we call them chronically hypoxemic patients, and they're going to exhibit certain clinical manifestations, and you'll see it all the time. Okay. I promise you, you're going to see it. You might not like it when you see it, but you'll see it. Okay, and again, the pharmacokinetic phase describes what the body does to a drug. And so the pharmacodynamics phase describes what the drugs does to the body. Does that make sense? That's Kathy's words, Kathy Miller's words. The pharmacokinetic phase describes what the drugs does to the body. Well, I'm sorry, what the body does to a drug. It absorbs it. It distributes it. It has to metabolize it, and it has to excrete it. And then the pharmacodynamic phase describes what the drug does to the body. So this is pharmacodynamics. What is this drug doing to the body? It's causing bronchodilation. And so a very simple name that we classify some of these drugs on this sheet are bronchodilators. Because what effect is it having? It's dilating the bronchi. Everybody who's short of breath or has a difficult time breathing will not need a bronchodilator because that's not why they're short of breath. But those that are short of breath because of this, you give them a beta-2 agonist. Give them a bronchodilator. Okay? All right. Any questions so far? All right. So let's talk about this bronchodilation. We're given this drug, and we know its classification very general. Bronchodilator, right? All right. For every drug that is administered, whether we administer it or not, it's always got to be an indication. How many of you set an alarm clock to get up? What's the purpose of that alarm clock?
To wake you up.
To wake you up. So the alarm clock is the indicator, time to get up. All right? So everything we do, and particularly with medication or any type of therapeutic services delivery, there's got to be an indication. I told you the other day, I just can't look at you and say you are adequately ventilating. I would hope that you are. But I can't make that call. I can tell if you're short of breath. I can see if you're using your accessory muscles, but I can't make that call. So it has to be an indication for a drug. So if a beta-2 agonist is classified as a bronchodilator, and that's indeed what we wanted to do, and I'll write that word up here. We wanted to bronchodilate, open up. Dilate means relax and open up. And this is airway, bronchi. This is the big ones and the little ones, which are bronchioles. And remember, this is 1 through 19th generation. We want them to open up. Well, what's the indication for this kind of drug? How do we know that a patient needs this kind of drug? The indication would be bronchoconstriction. Bronchoconstriction. That's the indication. A patient is experiencing bronchoconstriction. Now, I don't know how extensively Mrs. Sharkana got into the airway, but around the airway, particularly the bronchi, there's muscle. We have muscle and cartilage. The purpose of the cartilage in the airway is to keep it open. And not so much while you're inhaling, because you're inhaling air, and that'll keep it open. But when you exhale, after you've exhaled all that you've had in your lungs, the purpose of that cartilage is to keep your airway open so it won't collapse. Okay? What happens when you blow up a balloon, that's inhaling, and then you let the air out? It deflates, no air in it. That's what would happen to our airway if it weren't any cartilage in our airway. When we exhale, our airways would flatten. So the purpose of that cartilage is to keep it open. But around the cartilage is muscle. And so when we say bronchodilation or bronchodilate, we're talking about the smooth muscle. So what happens in asthmatics, and we don't know why, don't ask me why, I can tell you what happens, but we don't know why. We know the etiology too, but we don't know why. What happens in asthmatics, their airways become very sensitive, or you have allergies. All asthmatics, no, Kathy, you better not say that, because you'll say something different on pathophysiology. I'll just say most. Most asthmatics have allergies.
Is that an allergic reaction?
Yes.
Is it always that way?
No, I said most. When a person is exercising and they're outside and they start wheezing, that's not allergy induced. That's exercise induced. Or a person is allergic to perfume or allergic to shrimp and seafood, that's an internal allergy, but I don't want to, it's different kind of asthmas. But so let me just, allergies, allergic to trees, dust, mold, those kind of things, cockroaches, okay? They're exposed to this, and their airways, and when I say airways, conducting airways, are very sensitive. And they get real sensitive, and they kind of act crazy. And what they do, instead of remaining open so that the individual can adequately ventilate, everybody with me? They'll start doing this.
So that's why, like, if you're allergic to something, your throat will start to swell.
Bronchoconstriction, another name for bronchoconstriction is bronchospasms. They go into spasms. And how do we know? Can we see it? No. We can't see a bronchospasms. But now what I'm going to do is give you a term, or I call it clinical manifestations. I'll explain it a little bit more in Practice and Procedure 1 and Module 2 because I just did that PowerPoint. Anyway, how we know an individual is experiencing bronchospasms. We can't see bronchospasms. You can't see bronchospasms on a chest x-ray. We're going to take our stethoscope, and respiratory therapists know breath sounds. And abnormal breath sounds, first you learn what's normal, then you learn adventitious or abnormal. What we will hear that indicates to us their experience in bronchospasm is wheezing. Write it down. So when a patient is wheezing, they're experiencing bronchospasms and their airways are constricting. All right? So what's the indication for a bronchodilator? Bronchoconstriction. How do you know a patient is experiencing bronchoconstriction? Because you took your stethoscope, you listened to their breath sounds, and you heard wheezing. Yes, ma'am.
Okay, is that scenario that's isolated in time, right? That could happen.
I don't know what you're asking me.
Meaning that's something that could happen and then go away.
No, ma'am. When asthmatics go into the acute exacerbation of asthma, it does not go away.
So when they go to the emergency room, they know when they hear it because it's still going on.
And an asthmatic, after a while, will know their clinical manifestations, and they'll tell you. Yeah. And when you become proficient, you don't need a stethoscope. Sometimes my sister will talk to me, and I say, "You're wheezing." And she said, "I said, I hear it." After a while, you'll learn sounds in respiratory care. You won't need, sometime you will need it. But after a while, you can hear someone talking, and you, as a therapist, will know they're wheezing. Yes.
So, I'm dealing with a mother with COPD. When they're wheezing and they're
COPD is not asthma.
I know it's different.
The cause of wheezing in a COPD patient is not the same cause of wheezing in an asthmatic. Let me make that clear.
Okay. My question is, like, the medication-wise, like, when they're wheezing, either asthmatic or a COPD patient, and they do a rescue inhaler, and that's not working for them.
Rescue inhalers don't work for COPD patients.
Well, my doctor seems to be.
She probably using a controller as well.
She has both.
Okay.
So, but she does both, still not helping. you know.
Does she still smoke?
Oh, yeah.
Well, wonder why.
No, I know. It's like beating a dead horse, but,
You said that, I didn't.
unfortunately,
But I do understand what
Yeah,
you're saying.
But, you know, it's like at that point, I feel like, you know, it's like, wouldn't a albuterol, you know, treatment through the nebulizer be a bad thing to, you know, suggest they do, or a good thing?
I am being honest. As long as she smokes, don't do it.
It's not going to do any, yeah. That's what I thought, and that's what I tell
It's
her
not
all the
going to do
time,
any
but,
good. And the longer she smokes, I don't know what stage COPD she is, it's going to get worse. And when she gets to stage 4, it's terminal. And every time she smokes, there is a potential possibility of cancer developing.
She already had cancer. No, I mean, we've had the discussion. So, you know, it's like I know that I'm watching her for herself. So.
Yeah, and I know that may be difficult for you.
Yeah.
Right? Yeah, I can imagine. Yeah, but in a theory world, I would say absolutely. But realistically, as long as she smokes,
in the long run, it's just not doing it.
She's every time she lights up, she's doing more damage.
So basically,
to her
she's just
airway.
controlling the symptoms at that moment. It's just not going to have a long term.
And COPD is irreversible. Asthma is irreversible. You have asthma, but it's irreversible. Like the only time I wheeze is I get a cold or I get a sinus infection. But as long as I'm away from the stuff that makes me my nose run and wheeze, I'm okay. So when I come in here and you all see my nose running, it's just reaction. I'm allergic to dust. I was born to hire a maid, and so one day I'm gonna have a maid to keep my house dust free. But in the meantime, I work 3 jobs. Yes.
So what about an incident where a child, like the first 2 years of their life, shows and has symptoms being very asthmatic,
Well,
and then it kind of like goes away as they get older?
in boys, what's standard, and you may have a little girl, but what's standard, and they don't know why, so I don't either, because if they knew why, when I say they, medicine, little boys are generally born with asthma, and we don't know why, and by the time they hit puberty, they're done. Little girls begin premenstrual, and they have it the rest of their lives.
See, she had it when, my daughter had it when she was like 1 and 2.
Does it run in your family?
Not really.
How many months were you when you delivered her?
Oh, full term.
Full term?
Past full term.
I have no explanation for
Gotcha.
it. I don't know. But as long as she's getting better, wonderful.
Right.
All right, yes.
When we're talking about bronchoconstriction, that is the indication is bronchoconstriction. That is what is happening.
The indication for bronchoconstriction is you hear the breath sound called wheezing.
Okay.
And when you hear the wheezing, you know the patient is experiencing bronchoconstriction, and bronchoconstriction is the indication to administer a beta-2 drug.
Okay. So could you almost say the symptoms could be somewhat of an indication? So their symptoms is they are wheezing. We hear that they're wheezing through the
Symptom, wheezing is not a symptom.
Okay.
Wheezing is a sign. A symptom is what the patient subjectively tells you.
Okay.
Let me clarify. I can do this. You don't know if I'm pledging allegiance or having a heart attack. I have to tell you I'm experiencing chest pain.
Okay.
That's a symptom. It's subjective. So anytime you have a patient who's unconscious, no symptoms, because they can't tell you.
Okay.
But what you see and what you hear is objective, and those are signs. And together, signs and symptoms, Kathy Miller calls clinical manifestations. All right. But did I answer your question?
Yes.
All right.
Thank you.
All right. Any other questions? Yes.
I'm kind of going off on a tangent, but it almost sounds like that at that point, we're actually going to be allowed to diagnose a situation like this so we can apply this medication, or are we
You're not
following
physicians.
up? Exactly. Okay, that's what I wanted to clarify. We're following up and checking to make sure that this is accurate information. We get a record, the physician has diagnosed the situation.
Physician may not have to diagnose. If you have a patient wheezing as a respiratory therapist using protocol, you don't need a physician's order to give a beta-2 agonist.
Understood. Okay.
Yes.
I have a random question. I have a hard time breathing when there's no airflow. Like if I walk somewhere and the air is stale, I'll start having a really hard time breathing. Is that, does that have to do with humidity level? Because they were talking about it had to be like a standard percentage of humidity, or?
It could be humidity, or it just simply means that, do you have asthma? Okay, that's why you need adequate ventilation, so you need to make sure that you're somewhere where you can have adequate ventilation, and it could be, there's a term we're going to get to, but I'll just give it to you somewhere here. It could be your airway is hypersensitive. And so patients who have allergies and patients such as yourself, the airways are hypersensitive, and they respond to things where a normal airway wouldn't. Some people who have asthma are okay, but when it becomes extremely cold outside, believe it or not, that cold irritates their airway. And so sometimes, particularly the elderly, or it doesn't have to be the elderly, but I'm just using the elderly, you'll see them outside and you just think that their face is cold and they have their mouth covered with a scarf. It could be they have hypersensitive airways and they can't allow that cold air to hit their airway, and so while they have that scarf on their mouth, they're exhaling CO2, right? But CO2 is warmth, and they'll re-inhale just a small amount of that CO2, and it keeps their airways from going into spasms. Yeah.
I don't know, maybe this is off subject, but when you say spasms, if this were the inside diameter of the tube, all right, it's doing one of these numbers, right?
Yes, sir. That's what this is Kathy's. Yes.
All right, so when you're listening on a stethoscope, when you're hearing that wheezing is the constriction, the air going through that as it's constricting.
Yep. Because during ventilation, the flow of gas should be laminar. It should be smooth. Easy in, easy out, breathing easy. But when a patient is wheezing, that flow becomes turbulent. Okay?
That's what you hear, right?
And that's what you hear. We hear wheezing, yes. I had a little doctor, and what is this wheezing? And I'm like, I don't know, it's my asthma. He used to tickle me. He was a little German doctor. He would ask, what is this wheezing? And so I would, that's what I always tell my sister. I said, you're wheezing. Why are you, I don't feel it. Take the medicine, you're wheezing. All right. All right, everybody understand that. That's in general. Now we're going to get into this some more for Mrs. Shakana, but I want to get through this first. Terms for drug interactions. Antagonism. See this beta-2 agonist? That's antagonism. It says a direct chemical interaction between drug and biological mediator, which inactivates the drug. Example, okay, antagonism, taking antibiotics and drinking alcohol. When a person takes antibiotics, they shouldn't drink alcohol because the alcohol makes the antibiotic move, ineffective. A diabetic should not drink wine and alcohol. The end product of wine, end product of alcoholism is sugar. So they take insulin every day, but they have a glass of wine with the meal. Makes it ineffective. All right. Functional antagonism. It says can occur when two drugs each produce an effect and the two effects cancel each other out. So that would be like I can give you an example, but I don't want to give it to you because you don't know the terms yet. Don't worry about that. I'll come back to that. Number 3, synergistic or synergism occurs when two drugs act on a target organ by different modes of action. I was one mode of action. Kyle was another mode of action. But together, we rocked and had a greater effect on the action. Okay?
So it's two drugs working together.
Yes.
Thank you.
And potentiation, don't worry about potentiation. We're not going to get, because this was for another class. So don't even worry about potentiation. Okay, terms for drug responsiveness. Everything is not magic, unfortunately. Have any of you ever taken a drug and you were taking it for one thing, but it made you sick? Oh, yeah. Mm-hmm. Or I can't take the flu immunization. I took it one time. I'm not allergic to eggs. I can eat eggs all day long. But I took that flu injection and I wheezed for about 3 or 4 days. Got sick. Had to go back to my doctor. And she was apologizing. Kathy, I'm so sorry. Well, you didn't know. She didn't know. I didn't either. But I can't take the flu immunization. It makes me sick. I can take pneumococcal. In fact, I'm okay with pneumococcal for the rest of my life. But I cannot take that flu immunization. So, number 1 is idiosyncratic effect. Idiosyncratic effect. Effect that is opposite to or unusual, or no effect. It's supposed to do one thing. So let's do this. We have a patient that's newly diagnosed asthmatic. And we know albuterol is a beta-2 agonist, right? A bronchodilator. But this one particular patient, and I always use the number 10, we've given this albuterol drug to 9 new patients and it's done the job. They're happy. We're happy. Woo-hoo. We give it to the 10th patient and we know that it's a beta-2 agonist. However, for whatever reason, this individual's body can be allergic to this drug. So we're going to listen to breath sounds before we give the treatment, and then we're listening to the breath sounds during the treatment, and then we're going to listen to the breath sounds after the treatment. Now, although the wheezing may not subside, but at least the breath sounds should sound a little better after the treatment than before, right? We give this albuterol to patient number 10, and after they take the treatment, their wheezing is worse. That's idiosyncratic. And it was just based on their body. Sometimes patients take hypertensive drugs, or maybe you've taken an antibiotic, and you never took the antibiotic before, or you've taken it 100 times. That was me. Both of my sisters, I have one older, one younger, been allergic to penicillin all their lives. I haven't been. Polly, my granddaughter, had strep throat. I got strep throat. She got this. I got this. Well, I can't remember about 4 or 5 years ago, whatever I had to take penicillin for, man, I'm allergic to it now. It had an idiosyncratic effect. I broke out in hives, big red blotches. I was itching all over, and I wheezed. So I had to wait till I got 55. Now I know that I'm allergic to penicillin. I took it all my life, but I got age 55. And it was an adverse reaction, and it was idiosyncratic, so now I can never take penicillin again. And just people, individuals, yes?
When you have an allergic reaction and it's systematic, like it presents in, like, say, vomiting or, in your case, hives, can it easily become a respiratory event because it's affecting your system?
Depending on what it is. I could say yes and I could say no. You have to be more specific, and I probably could give you more of a specific.
It is just a personal thing, because my son's allergic to chicken and turkey, and when he gets it, he gets like violently ill, projectile vomiting. But he's never had anaphylaxis or any breathing problems with it, but his allergist still wants him to have EpiPen with him.
Because he may one day.
Yeah. Because she says it was systematic.
The potential is there. I didn't go over potentialism, but the potential is there. He may never experience, but it's better to have an EpiPen and not need it than to need an EpiPen and not have it. Yeah. So teach him how to use it. How old is he?
3.5.
Not yet, but when he gets about 5, teach him how to use it.
It comes with they always come with a practice one.
Absolutely. Teach him. You have to teach him. That's why I had my granddaughter in my life, because she had asthma. And I went to the doctors and said, come on, not that I wanted to, diagnose her with asthma so I can begin to teach her. And after they did, and they listened to me and whatever, she knows. So when she was 5 years old, she could come to me and tell me she needed a treatment and tell me why she needed a treatment. Because she suffered. Now she's older, she's fine. She doesn't know that I know, but I know she's smoking because I smell it. I tell her, you stink. Oh, I was around somebody. I'm like, yeah, I was born yesterday. Okay, idiosyncratic. So that's an unusual effect. It doesn't happen with everybody. Okay? Another way, and it doesn't have to be medicine, idiosyncratic. A patient comes in the hospital and a procedure is done. And after the procedure is done, they're sick. They're critically ill. That's idiosyncratic. Okay. It was caused by doing something to the patient or caused by some kind of medication. Okay, hypersensitivity. This is an allergic or immune-mediated reaction to a drug which can be serious, such as what Rachel was speaking of, requiring airway maintenance and ventilatory assistance. She said anaphylactic shock. And so allergies that are very severe will do this to the airway, close them. Not only, they'll first go into bronchospasms, and maybe within a minute, they'll shut down. And when they shut down, the potential is that the patient will go into respiratory arrest. That's hypersensitivity. So all asthmatics have hypersensitive airways. And there's other kind of patients that have hypersensitive airways, but asthmatics do. If I'm around dust, and I had to not raise hell, but I got ill back in the spring. And I left here one day really ill. And I told my dean I can't come back. They had to come clean these vents out. Because it had been winter and the snow and all that, and then they decided to turn on the air. I got sick because I'm allergic to dust. And it was in a matter of an hour. And I went home ill. And I told my dean, I'm not going back to the lab till they clean these vents. I am allergic to dust. This is called sick building syndrome. And I know I'm not the only asthmatic around here. However, I may be the only one that voiced an opinion. Now, if you want me to come to work, they must clean these vents. I demanded it. I got really, really sick. I was listless. And the older you get, people, the longer it takes for you to spring back. All right. So hypersensitive, and particularly for us, it's hypersensitive airwaves. Okay. So hypersensitive airwaves are going to go into bronchospasms. And then therefore, there's going to be that's going to be the indication for our beta-2 agonists. And what is the goal of our beta-2 agonists? Bronchodilation, to open the airways up. Okay. So anytime there's adequate ventilation, it's called laminar flow, smooth flow, breathing easy. But anytime your airways begin to constrict, particularly your bronchi, they begin to do this, it's going to affect ventilation. It's going to affect how much oxygen gets in, and it may affect how much carbon dioxide gets out. And so it's going to affect ventilation, and we may see changes in the blood gases. Does that make sense? All right. Then number 3, tolerance describes a decrease in intensity of response to a drug over a period of time. So let's go back to the sheet under asthma. And you have a patient who has asthma, and it doesn't matter whether they use ProAir, Proventil, Ventolin, all same thing, right? And they've used this drug for about 12 years. This is an example. Everybody won't experience this, but I'm just using this. They've used this drug for about 12 years. And what has happened, they've been using it and it's worked. But now their body has developed a tolerance to the drug, and the drug is not as effective. And so the patient knows that the drug is not effective. They may not go to their physician and say, I have a drug intolerance. They may not say that. But they say, you know, I used to only have to take this albuterol once a day. Now I find I have to take it every 2 hours. Well, that's misuse of the drug. And so the physician will know that this drug is not effective. And so now that this drug is not effective is when you go to the far right, and now the patient may have to take Combivent. Not only take the albuterol, but take another drug with it because they develop a drug tolerance.
So are combination drugs only for tolerance? Like,
When one drug doesn't work, you have to have 2, yeah. Or it could be the patient is newly diagnosed And you've given them one drug, and it's not working. And it's obvious it's not working. They may need a combination of 2 drugs. And they may have to go home on that combination, just depending on the severity of whatever they're dealing with. Yes,
In the case of a sensitive airway or asthmatic, just like to use an example about the elderly person, maybe asthmatic if the cold air affects them, does it take longer for their nose to be able to warm that expired air?
It doesn't have anything to do with the nose because the pathophysiology is in the bronchi.
Okay.
It's the bronchi. So it doesn't matter whether they're breathing through their mouth or their nose.
Okay.
However, the nose is the preferred method of breathing. That's a good question, but it doesn't matter. All right? Okay, so a drug tolerance is when it happens over a long period of time. Doesn't work anymore. Next word, number 4, tachyphylaxis. Describes a rapid decrease in responsiveness to a drug.
How do you say that?
Tachyphylaxis. Tachyphylaxis describes a rapid decrease in the responsiveness to a drug. And then drug dependence, everybody kind of knows what that is, right? Mm-hmm. All right. Now listen to this. We know oxygen is a drug, right? Some patients, it's not physiological, it's psychological. Some patients, such as some COPD patients, CO2 retainers, they become dependent upon oxygen. They really don't need it, but they think if they don't have it, just automatically the doctor takes away the oxygen, they start breathing hard. They become tachypnic because they're psychologically dependent upon the oxygen. Based on their body, they don't need it. So that's physiological. But some patients become psychologically dependent. And so, not in the case of oxygen, but in the case of other drugs, this is when the physician will give them placebo drugs, sugar pills. And just the mere fact that they're taking medication, they feel so much better. Oh. And sometimes that's what happens with the elderly. Does it make sense?
Maybe like a person, can they get drunk off of oxygen?
No, oxygen, too much oxygen will cause a respiratory arrest and death. Yes. Make sense? All right, yes.
Can someone ever become tolerant to synergistic?
Absolutely.
What do they do then?
They need something else. They probably need to stop smoking. Because I'm going to bet my profession on it. If they become tolerant to complement, they're still smoking.
Yes. I know you got to quit smoking. I know smoking's bad. What's your take on electronic cigarettes where it's a vapor?
Don't do it. Don't do it. Your lungs are precious. Don't do it. All right. Terms for drug dosages. Minimum dose. Smallest amount of drug that will produce a therapeutic effect. That's why it's important to start with a minimum dose. Because if you give the maximum dose initially, that means the patient is at risk for developing a tolerance to it. You can't give more than the maximum dose. So just take if you can get away with 1, don't give 3. Minimum dose. If the minimum dose is effective, stick with it. And then you have some latitude if you need a greater dose later on. Make sense? Minimum dose. Maximum dose, the largest amount of a drug that will produce an effect without producing toxicity. Now, if the patient needs a big dose, give it to them. But generally, when we deal with maximum doses, these are in life-threatening situations. And it'll save a life. Loading dose, initial high dose. Elevate the drug in the blood. You have an infection. And you go to the doctor. And the doctor says, I'm going to write you a prescription, but I got to give you an injection while you're here. Why? While they give you the injection, because you got to take the prescription and go get it filled and then take it orally. The advantage of oral is simple and easy, but it takes longer to get in your system. So what the physician will do will give you a loading dose injection, generally in your butt, your tush, Kyle, not your ass, your tush. because ASS is the American Standard Safety System, right? Give you an injection in your thigh, meat, and that'll be your loading dose. And so it's in your system once you get the prescription filled.
So it's a jump boost.
A jump boost, good name, yes.
It's like, when you're taking Z-Packs, is that the same thing as a loading dose?
No,
It's
no,
like sometimes, it's like a stronger pill, and then you take less and less as the days go on.
no, that's not the same thing. A loading dose is generally a different route of administration for the initial dose, then you take the Z-Pack.
Gotcha.
So it's like having a prescription for penicillin or whatever kind of antibiotic in your hand, and you're going to get it filled, and you're going to take it for the next 7 or 10 days. But while you're in the doctor's office, they give you an injection of that same drug. That's a loading dose. Yes. Okay, maintenance dose. That's the dose required to keep the drug at a steady level. So your patient is receiving albuterol, and the doctor writes an order, albuterol with normal saline every 4 hours or every 6 hours. So every 6 hours, you've got to go back and give the patient another treatment, because that drug had a peak effect in the body. And when it had a peak effect, then the drug began to wear off. And they're still wheezing. Wheezing has subsided somewhat, but not completely. So you have an asthmatic. An asthmatic may have to be hospitalized for 3 or 4 days. Now, you see them the second day. They're still wheezing, but the wheezing is not as bad as when they came from the emergency department to the floor. So they may need you to give them their bronchodilator every 4 or 6 hours for maybe 48 hours. Okay? So you want to maintain that therapeutic dose within their blood, because if that therapeutic dose is not maintained in the airway, then they'll start wheezing and get worse. Does that make sense? All right. Just like you taking antibiotics, the prescription says take the antibiotic 4 times a day. That's what you need to do. And it maintains a therapeutic dose of that drug within your system to fight off the pathogens. Yes.
So is the difference between a minimum dose and a maintenance dose? Minimum is something the patient can take themselves.
A minimum dose the doctor prescribes. A minimum dose means the drug has a range. The drug can be between 2 and 5. If 2 is effective, don't give 5. If 2 is effective, don't give 3. If 2 works, don't go to 4.
So maintenance can be anywhere in between.
Minimum dose can be 2. Maintenance dose can be 2. As long as 2 works, wonderful. Yes. It's effective. What do you mean, what's the circumstances? What do you mean? Drugs come in ranges, 2 to 5. If I can give 2 and I see that is effective, patient responding to minimum dose, that's all I'm going to give them. They don't need any more. Because if we give more than the minimum dose and they don't need it, the greater potential for side effects. Yes. I can't hear you. Air's on.
For the loading dose, this means it's always be given by to IM, like intramuscular?
Most of the time. It's a high initial dose.
So most of the time, but it could be some other means also, like oral or?
Oral is not a loading dose. It's too slow. It's too slow. Initial dose is sped up, and the GI tract is too slow. It has to be absorbed and it has to be distributed. A loading dose is administered some other kind of way and gets in the system a lot faster. Oral is wonderful because you swallow, but it takes longer to get in your system, and that's not a loading dose. Okay? All right. Next is toxic dose, amount of drug that will produce harmful effects. So Letitia, if you start out with a maximum dose and it's too much for the patient, it's going to cause toxicity. Okay.
So it's like pain meds, right? They try to get a balance. I mean, when you first come in, they load you up, and they try to get to a flatter level, so you're not, if you need more, you can get it versus your max, they can't give you any more.
Absolutely. It's like eating Oreos. You love Oreos. The indication is you need a sugar rush. Eat too many of them. It's going to make your stomach hurt.
Nope.
You'll get diarrhea.
Nope.
And you probably won't want to eat anymore until tomorrow.
Nope.
Too much of anything is not good for you. Right?
Right.
All right.
Oreos and chili dogs.
What did he say?
All right.
Oreos and chili dogs.
Nice.
And then lethal dose causes death, and therapeutic dose, dose that is customarily given, adjusted according to variation. So therapeutic dose, that's a good dose. A therapeutic dose probably would be the maintenance dose.
The same thing.
Could be, not be, depends. Or if I have a drug and I know I can give the drug in range, let's say maybe I start out with 0.2 cc's. And gave it to the patient, wheezing about the same. Now the range is 0.2 to 0.5. So then maybe I go back and the next time I give the patient 0.3. And when I give the patient 0.3, then after the treatment I hear they're not wheezing as much. The minimum dose was 0.2. But now this time I gave 0.3 and I got better results. So 0.2 was the minimum dose, but now in this case, 0.3 is the therapeutic dose because I got better results with 0.3. See the difference? And then I know I can't exceed 0.5. But if I can get better results, if I hear that wheezing subsides, may not completely go away, but it subsides at 0.3, that's what I'm going to continue to give the patient so that they can maintain that therapeutic dose within their blood, and every time I give it to them, wheezing is going to improve. Or I should not say improve, subside. Yes.
So, and if you, just in this scenario, doctor says 0.2, give the patient 0.2 of the therapeutic drug. You do that through, the nebulizer thing, and then you see that it's not working. Do you have to go back to the doctor to get
Let them know.
0.3?
Yeah, and it
Okay.
depends on where you are. Protocol may say give what you think they need.
Okay.
And then after you give it, you can contact the physician, say, I gave him 0.2, wheezing didn't improve. 4 hours later, 3 hours later, I gave him 0.3, and this is most effective. Will you please change the order?
Okay.
You have that authority. Okay? Got it? So it just depends on what and again, these are terms. Now, on page 3, it says, as a healthcare learner of pharmacology, you may find it helpful to prepare cards because there are so many drugs to learn. You may use 3x5 or 5x7 inch index cards to assist you. Drug cards should be typewritten using 10 or 11 pitch on Georgia, Arial, or Calibra font. This is what I want on each drug card. 8 things. 1, generic and trade name of the drug. And how are you going to write the generic name? Small letters.
Small letters.
How will you write the trade name? Bold or all capitalized, your choice. Either one is right. Okay? I want classification of the drug. It's all there. Forms and routes of administration. And if it's just inhalation, say inhalation. Or if it's MDI, let me know it's an MDI. If it's DPI, let me know it's DPI. MDI is metered dose inhaler, MDI. DPI is dry powder inhaler. Or if you have to administer it with a small volume, and I keep pointing over here like you know what I'm pointing to. We'll get to it. Or a small volume nebulizer. How are you going to administer it? All these drugs are respiratory care drugs. So none of these drugs you're going to tell me it's administered IV or intramuscular or suppository. That's not us. We work out of this end, inhalation. All right? Okay. Next is indication. What's an indication for the drug? Well, most of the drugs that you're going to talk about, the indication will be bronchoconstriction. Most of them. What are side effects? We're going to go through side effects. All this information is in the text. You don't even have to go to another source. All right. What are the contraindications? When do you absolutely not administer this drug? Well, one I can tell you, if a patient's allergic to the drug, that's a contraindication. I'm allergic to penicillin, so it's a contraindication. Can't give me penicillin. I'm allergic to iodine. I can't do a contrast dye MRI. It'll kill me. And it's very, very important for patients to know their allergies. And if they're not cognizant of their allergies, and you happen to find out because you're helping them or whatever, let them know they need to know allergies. Very, very important. Allergy will kill individuals. Okay, dosage and customary route, and any special instructions needed for the medication. And then I will tell you, you can't write all that on a card, but let's say it's an MDI. I gave you a handout on MDI. What you'll do for those instructions will say MDI instructions. Okay? Now what I'm going to do now, this is what I want on the cards, 1 through 8. What I'm going to do now, and they're kind of beat up because I've held on to them. These are drug cards somebody gave me. You can do them how you want. Like I said, some people are fancy smancy. I'm not requiring that you do it. But some people laminate them. But however you do it, remember the sole purpose of this is not busy work. Kathy Miller knows drugs. Got it? You're going to do these drugs and give it to me. I'm going to correct them, and you're going to get a score for it. But when you go to clinical in the winter, you're going to have these drugs in your pocket. And so it'll be a reference for you to pull out. And by next summer, you'll know them. You'll know them back in your hand. So I'm going to pass these around. For some people, they found it, and I do think it's difficult. It's difficult to write this stuff out on the card. So some people typed it out, as you can see, and then they pasted it. Or you can do whatever you want to do. If you want to do color 3x5 cards, I don't care, because these will be your cards. But what I do need, Ebony, I do need a top 3x5 or 5x7 index card with your name on it, so I'll know whose cards they are. Okay? If you don't want to do a ring, you know, you can go to CVS Rite Aid and you can buy, what do you call them, 3x5 cards that are bound in a spiral little book. You can do that, and then you've got to figure out how you get this information on here. So I want you all to take a look at these. I only had one set. Somebody gave me, Miss Miller, you want my cards? I'm like, sure, I'll take it. All right. And then 6 parts to a medication is chapter 2, and I'll go through that. Hang on to this. Let's look at this clinical scenario. A resident orders albuterol, and then I'm being nice, I'm telling you Proventil and Ventolin, a bronchodilator / a beta-2 agonist. Did we not go through that?
Yeah.
Okay. To be given BID. What's BID? Twice a day for a 67-year-old male. The patient has been diagnosed for the past 10 years with COPD and was admitted to the hospital the previous evening with a respiratory infection. At 8 a.m., you administered the prescribed aerosol treatment via a small volume nebulizer with the usual recommended dose. Usual dose. Okay, that's protocol in your department. After the treatment, the patient's respiratory rate is reduced from 22 breaths per minute to 14 breaths per minute. So right there, was the therapy effective?
No.
Okay. Sure it is. What's normal respiratory rate?
12.
So his respiratory rate was 20 and then it's dropped to 14. Yeah, it was effective. And there is less accessory muscle use. I know you all didn't get this far, but maybe you did. Did Miss Manal talk about the main muscle of inspiration? The main muscle of inspiration is the diaphragm. That's the only muscle that you use when you ventilate normally. But now if a person is having a difficult time breathing, they're going to use accessory muscles. And that's bad. That's a clinical manifestation. That's objective. I can see. I don't know if you're having a difficult time breathing, right? You have to say, oh, I'm having such a difficult time breathing that I can document dyspnea. Not dyspnea, but dyspnea. Difficult breathing, right? But I can see you using accessory muscles. And so this therapist has noted the patient's rate dropped from 22 to 14, and there's less accessory muscle use. Therapy was effective. They're not as using many accessory muscles, and their rate has dropped. So what does that mean? Because this COPD patient received a bronchodilator, he's breathing easy. Is it reversing the COPD? No, but he's breathing easier. Wheezing upon auscultation has also decreased. Less wheezing. Make sense? All right. Although you hear adequate breath sounds bilaterally, he seems less, Kyle, not SOB the way you're thinking, less short of breath. So he's less short of breath. And I know he's less short of breath because I see he's not using so many accessory muscles. Make sense? And I see, I've counted his rate, and his rate has gone from 22 to 14. Breathing easy, baby, because we gave him a bronchodilator. Okay? Now it says, however, at 10:30, he's exhibiting moderate respiratory distress using his accessory muscles. The patient is complaining of dyspnea, and the patient has increased wheezing on auscultation. That's bad. Okay? His next aerosol treatment is not due until around 6 p.m., but it's 10:30 in the morning. He admits he's having chest pain. Both wheezing and breath sounds can be auscultated, heard over his entire chest. So now, here you got a patient in distress, and the doctor has written a treatment only BID. Do we say, well, you can't have a treatment because the doctor only said you can have it twice a day? What are we going to do? You got to give him another treatment and contact the doctor. You have that right because you have protocol. Just because a doctor wrote an order, and again, I'm not disrespecting the medical field or disrespecting the doctor, but the doctor wrote the order based on how the patient was presented when the doctor saw him. But this patient's in distress, and if we don't do something for this patient is going to have a respiratory arrest. So we're going to step in and handle it. And we're going to administer a beta-2 agonist. Yes, ma'am.
Just out of curiosity, is it possible that it is an allergic reaction? Do they delay like that, or are you going to have an allergic reaction right away?
No, this tells us above there, we said, you hear adequate breath sounds bilaterally.
Okay.
If it was an allergic reaction or if it was an idiosyncratic reaction, we know immediately.
Okay.
Nope. This patient got better. His respiratory rate wouldn't have dropped from 22 to 14 if it was idiosyncratic.
There's not going to be a delay like that?
Nope.
Okay, just check.
Yes.
What does it mean, breath sounds bilateral?
What does bi mean?
Two.
Two.
Yeah.
You have two lungs. What does lateral mean?
Sides.
Both lungs
sides
equal,
are
bilateral. Okay? We have to do something.
Yeah.
Okay. You review the pharmacokinetics of albuterol and find the following. The onset means it's effective in 15 minutes. Its peak effect is 30 to 60 minutes. And the duration of the drug, therapeutic dose in the bloodstream, is 5 to 8 hours. What may be likely a cause of this patient's respiratory symptoms, and what solutions can you offer or recommend?
Did we not give him enough?
So, I want you to think about it. Think about it, and we'll talk about it on Tuesday. These are the kind of things that you're going to deal with. I'm going to introduce you to the clinical environment soon because I don't want you to bank all this wealth of information and then not be able to apply it. This is why you're learning pharmacology, because this pharmacology stuff, information, will apply to a patient. And so we got a man, the doctor's written an order, but we see he's in distress. Do you want to work harder later on and when it be time for you to go home? You can't go home because you're working on a rapid response or a cold blue. intervene, step in right now, and give the man what he needs. Okay? He's telling you, I'm having a difficult time breathing. You see him using his accessory muscles. You see he's short of breath. You hear that his wheezing gets gotten worse. Make a decision on what needs to be done for him. Okay? All right.